तर मला एकच रिक्वेस्ट आहे की जे ऍडमिट करायचं आहे ना ते
हा
तुम्हाला कोणाला तरी करायला लागेल. माझं लेक्चर असताना मग मी ऍडमिट करू शकत नाही.
नाही, तुम्हाला ऍडमिट कोणालाच करायचं नाहीये. तुम्हाला
हम्म.
फक्त बोलायचं. ऍडमिट कोणाला करायचंय तुम्हाला?
नाही नाही, आता डॉक्टर वैशाली गंभीरेचा आलेला ना, त्या वेट करत होते, तर
हो
माझ्या
हो,
स्क्रीनवर ऍडमिट आलेला.
तुम्ही नका करू.
तर ते तुमच्या स्क्रीनवर पण आलं का असं
हो
विचारते.
हो, येते येते येते. तुम्ही
ठीक आहे.
त्यामध्ये तुम्ही फक्त सेशन मध्ये फोकस करा.
येस, दॅट इज व्हॉट आय वॉन्टेड टू लेट यू
येस.
नो.
आणि वी विल मेक इट लाईव्ह ऍट शार्प 3 PM. वी विल स्टार्ट ना.
ओके, अजून 3 मिनिटं आहे.
हो, आहेत. वी आर वेटिंग फॉर जयंत पळसकर सरांचं. धेंडे सर, टेक्निकल टीमचं कोण आहे का? कम्प्युटर सेक्शन.
शास्त्री मॅडम नमस्कार.
नमस्कार सर. कॅन आय स्टार्ट? इट इज 3
No,
o'clock.
no, we'll tell you. We'll just see. When it's
आता केलं.
good afternoon, all of you. I request our respected Dean Madam to introduce our today's guest speaker, Dr. Jayanti Shastri Madam. Over to Dean Madam, please.
Very good afternoon. Warm welcome, ma'am. So, as part of the Galot Rao Ahir lecture series, the URD department has invited our chair professor, Dr. Jayanti Shastri ma'am, to give her talk on antimicrobial resistance and One Health. Just a brief introduction of ma'am. She has done her undergraduation from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Varda. Her post-graduation, MD Microbiology from LTMC Science. She was former head of Department of Microbiology at NIAR, former lab director, molecular lab, Kasturba Hospital, PI at Viral Research and Diagnostic Lab, again Kasturba, Mumbai, and PI Center of Excellence in Immunology Research, NIAR Hospital. She has planned and commissioned a state-of-the-art molecular diagnostic facility at Kasturba Infectious Disease Hospital in Mumbai, which I personally have really gone and seen, and it's really huge and vast and very well equipped, which is a molecular public health lab receiving samples from 4 tertiary care and 16 secondary care MCGM hospitals for leptospira, dengue, chikungunya, PCR, hepatitis B and C detection and quantitation. Lab conducts 15,000 PCR tests per year. As far as COVID-19 is concerned, it was the first ICMR designated COVID testing lab in Mumbai for conducting RT-PCR tests since Feb 20. Lab is an ICMR designated validation center for antigen test kits and quality assurance lab for private labs conducting COVID testing in Mumbai. It is commissioned for genome sequencing for entire city of Mumbai and has sequenced around 5,000 samples to date. Is a center of excellence in immunology research, immune signatures in COVID-19 research. The lab is recognized by the National AIDS Control Organization as regional HIV reference lab for conducting HIV viral loads by real-time PCR and early infant diagnosis by DNA PCR. Madam has received training in PCR at Research Institute for Microbial Diseases, Osaka University, Japan. She had received Fogarty-funded Visiting Scientist Fellowship at Albert Einstein College of Medicine, New York, USA in 2009 under the AIDS International Training Program. So with her huge knowledge on such varied topics in microbiology, today Madam is going to enlighten us on antimicrobial resistance and One Health. Over to you, Madam.
Thank you so much, Dean Madam, for this very, very kind introduction. Good afternoon to everyone, and I thank MUHS URD department and Dean Madam for giving me this opportunity to speak to you on antimicrobial resistance and One Health. My 4 decades of experience in clinical microbiology has taught me only one thing. Because we've been struggling with antimicrobial resistance. And the thing which I learned is behavioral change is extremely hard to achieve. So I will just give you some idea about this silent epidemic that we are facing and what measures we as a medical community should do in order to tackle this resistance issue. I'm not able to change my slides. Yeah. So we all know that William H. Stewart, who was the Sergeant General of the United States, that it is one of the most infamous quotes in the history of biomedicine. It is time to close the book on infectious disease and declare the war against pestilence won. This was the statement made when penicillin got the FDA approval. We all know how we are grappling with this silent epidemic of antibiotic-resistant organisms and emerging infections. Antimicrobial resistance, bugs, the super anti-hero. So these are the bugs, and we all know that the resistance actually bugs them. So what is antimicrobial resistance? It is the ability of the microorganisms to resist the effects of antimicrobial drugs, which is a natural phenomenon because the microbes existed much billions of years before mankind. So they were already evolved when there was evolution. along with the evolution, they also evolved and developed resistance to drugs as they got exposed. So this is called as acquiring resistance against a selection pressure. But human action is making it worse because of poor sanitary conditions, inappropriate food handling. If you do not have proper sanitary conditions, don't have running water, your hands are contaminated, then you can spread these organisms, the drug resistant organisms, through food. Patients not taking antibiotics as prescribed. Many times we see that the antibiotics are prescribed for 5 days or 6 days, but as soon as the patient starts feeling better, at day 3, he abruptly stops taking the antibiotics, which causes evolution of drug resistant mutants. There is a lot of misuse, overuse of antimicrobial drugs in healthcare and in the breeding of crops and animals. We have seen in the breeding of crops, a lot of antibiotics are used along with the pesticides. The animals are given antibiotics as growth hormones. In poultry, we face this huge problem of they being fed with antibiotics in order to have high quality of the eggs. The other issue is lack of rapid diagnostic tests in the laboratory. If you want to know whether the infection is by a bacteria or a virus, there are very few options available, and those which are available are expensive. A simple solution will be to provide these rapid tests in the laboratory to improve the antimicrobial stewardship program so that giving antibiotics can be avoided. Poor infection prevention and control practices in the hospital. This is a topic by itself, and through the MUHS, we will be coming up with a fellowship program and a certificate program in infection control prevention in the hospitals. So antibiotics are losing their power. So it's a diverse interplay. Antibiotics on human gut bacteria, they are released in the sewage, in the water. Then veterinary antibiotics are given to farm animals, which are transferred to the food. Then they also contaminate the soil, and the same soil where we have our vegetables and fruits which grow, and the antibiotics can seep into. So what I'm trying to say is we are already consuming a lot of these antibiotics in suboptimal concentration, which gives rise to inadequate concentration to the human gut bacteria, leading to mutations and presence of drug-resistant bacteria, which can cause endogenous infections. Now, drug resistance. There is a weak surveillance. Drug quality. Are we testing the drug quality which is provided to us? Does it have the optimal concentration of the drug under consideration? There is irrational drug use. Infection control has actually gone for a toss many a times in public hospitals, maybe because of lack of commitment towards the right things, and there is lack of research. So what is the impact of antimicrobial resistance on the community? On the community, there is difficulty in treating infections, which leads to prolonged illness and increased risk of death. Imagine a situation where operation is successful, but the patient dies of infection with antibiotic resistant bacteria. We are not far away from that sort of a situation. What we have seen is antimicrobial resistance, 10 million in 2050. Deaths attributable to AMR every year compared to other major causes of death. Which is actually the estimate is very low. 700,000 is very low because there is no surveillance. Once we start active surveillance, we will know the burden of disease. By 2050, the death toll could be staggering. One person every 3 seconds if AMR is not tackled. Spread of deadly diseases. There can be outbreaks of deadly diseases, especially which are dangerous to the healthcare setting because of spread of hospital bugs within the hospital. This is a very important diagram. Spread can happen between animals. It can be animals to humans. It can be spread in the environment, including via contaminated water and fertilizer, and spread can happen between humans. So this is a vicious circle. Now we have to break the chain of infection. And how do we do that? There are really lack of new antimicrobials. Development of new drugs is very slow, and there are limited treating options. We can see the drug development. We had penicillin as early as 1926, and we saw penicillin resistance in 1940. 1950 was tetracycline, then 1970 vancomycin, imipenem, ceftazidime. Then we have linezolid, ceftriaxone, and daptomycin. Now you can see there doesn't seem to be really any light at the end of the road. So what are you going to do? We have very limited, just a handful of treatment options. So judicious use of antibiotics, rational use of antibiotics is the only way forward. There are no new class of drugs introduced since 2000. There is increase in healthcare costs. We have seen that there is a yawning gap in costs between the public and the private hospitals. So this has an economic impact and a negative impact on the economy when there are antimicrobial resistant bugs involved in infection. And you can see the impact of AMR by 2050 would be wide-ranging. This is a document from the World Bank. 28 million people projected to fall into poverty because of AMR. Up to 7.5% decline in global livestock production. 3.8% decline in global exports. And up to $1 trillion loss in global increase in healthcare cost. How can a government support healthcare costs in infections which are drug resistant? So we all have a responsibility. We have a collective responsibility. The medical community are just firefighting in the hospitals. Everything is happening outside the hospitals, and patients are coming with resistant organisms when they are admitted to the hospital. This is a growing crisis. We all know this. And the full impact is unknown because there is no system to track AMR globally. Without urgent action, many modern medicines could become obsolete, turning commonly infections into deadly threats. It's sadly silent because it has not been discussed like other pandemics, and of course has been in the shadow of the COVID-19 pandemic in recent years. Major public health concern that requires urgent action to address. Most of the times, AMR is discussed in medical microbiology conferences. Why not with clinical medicine? Because the handle of giving antibiotics, handle for authorization in the hospitals lies with the clinician. Therefore, it is extremely important that the clinical community works hand in hand with the medical microbiologists in the hospital and have a good antimicrobial stewardship program to combat resistance. South Asia, you can see the deaths associated in 100,000 population is much above 50. It is almost 80 deaths per 100,000 population. Now, this is a Lancet article. And we also know the use of antibiotics in aquaculture. So when you use antibiotics in aquaculture, imagine already feeding yourself with some amount of mutated genes which could be present in that fish which is consumed. So when you use it for aquaculture in suboptimal concentrations, in order to maintain the species, then you may be already consuming some amount of genes which can be translocated in on your gut bacteria. Climate change is also contributing to a lot of horizontal gene transfer in the environment, and therefore you could be also be part of all these changes which are taking place in and around us. What are the challenges in detection of AMR? So much has been discussed about AMR. What is the biggest challenge? Why is there a lackadaisic attitude towards discussing this matter, towards implementing any change in the hospitals? Because there are very few options available for the clinician to know whether he is dealing with a bacteria or virus. Many times the clinician tells the lab people, I am here with the patient. I am the one who's treating the patient. I am the firefighter. You are sitting in the lab and you are telling me, don't give antibiotics. If I don't give antibiotics and the patient dies, who is responsible? So in the laboratory, we definitely need diagnostic methods just to identify whether in any infection we are dealing with a bacteria, a virus, or a fungus. So there has to be proper identification, which has to be as rapid as possible. It should be, cost is always a concern when it comes to public hospitals. I have worked in public hospitals for 4 decades, and I know how the budgets are drawn. So we really need to give it a thought. There is lack of data because there is limited access to diagnostic testing. There are quality issues. Why do we say that there is lack of surveillance? Because across hospitals, the methods which are used for testing antimicrobial sensitivity are varied. Public hospitals, all of them do not have automation. Some of them do have. In the absence of automation, accurate, high quality results may be a problem, but I'm not saying the conventional methods are not good. Conventional methods are very good. However, they take time. There is no linkage of microbiology and clinical data. You have to see the clinical outcomes. When you give a sensitivity report to the clinician, it has to be followed up. The clinical microbiologists, it's high time they leave the laboratories and they go for rounds with the clinicians and try to see whether whatever sensitivity which has been reported by them has been implemented, has been given to the patient. And if higher antibiotics are given, then de-escalation is important after you get a sensitivity report, because generally they start with higher antibiotics and then they de-escalate. There is a lot of duplication of data. There is lack of standardization across labs, as I told you, because of the various methodology differences. So there is a discordance in AMR identification between public and private testing centers and across the country amongst all the labs. Some private hospitals, they do use automation, and whereas some public labs are dependent on conventional phenotypic tests, especially for identification and susceptibility testing. Specialized tests need to be introduced. As I told you, BioFire is a rapid PCR test which can give you results in 1 hour. And now they have come up with a new equipment which can give you results in 15 minutes. It's a boon for the clinician. But can we invest 12,000 rupees per test per patient? What is going to happen? It's going to be a huge economic burden. There is expert Carba, which is about 4,000 rupees a test, and rapid tests within 15 minutes, like an immunochromatography, which is an immunological test, is available for 2,200. Most private hospitals are using this test in their antimicrobial stewardship program to support the clinician from avoiding giving antibiotics. So when I say that you must use antibiotics judiciously, I am also saying that labs need to have some support for the clinician in enabling a good stewardship program. The characterization of AMR in public hospital testing is mainly phenotypic. There are agar dilution methods, gradient tests, disk diffusion, broth dilution. Automation is available in public hospitals, but it is used only for pediatric patients and ICU patients, again because of cost. If automation is available for all patients, it is actually a very good, the turnaround time is very fast and it is a good option. Although generally easy to perform, phenotypic tests may require multiple tests for conclusive findings, laborious, time-consuming, not always specific, may not be accurate, do not detect all resistance mechanism, interference, and inconclusive data, may not identify resistance in microorganisms that are difficult to culture. See, phenotypic tests are extremely good in cultivable organisms. But we have a number of microorganisms, bacteria, which are not cultivable, like the mycoplasmas. We cannot cultivate them. Ureaplasma, it is difficult to cultivate. Lower sensitivity may not be able to detect resistance in microorganisms that are present in low numbers or present in mixed population. The other challenge which we face is variability amongst the technicians who are performing these tests. When there is so much of difference which is seen in these phenotypic tests, the way forward is, of course, to invest in good quality diagnostics or have genotypic methods such as PCR, sequencing, genotyping, which can provide a more complete picture of the resistance mechanism, improving the accuracy of resistance detection and characterization. Everybody knows RT-PCR now. I think the COVID pandemic was important for awareness creation in RT-PCR. Everybody knows the role of a medical microbiologist who was so important in diagnosis and again in infection control. And we all know that genotypic methods can really replace phenotypic methods for rapid identification of the presence of the antimicrobial resistant genes. So what needs to be done? The most important is have a robust infection prevention and control program. it will really go a long way in reducing the number of hospital-acquired infections. Simple hand washing techniques, hand hygiene needs to be incorporated in your genes. Like there is a very common saying, incorporate hygiene in your genes. When we say, the examples given by number of healthcare professionals in public hospital is the wash basin was far off. There was no liquid soap available. There was nothing to dry my hands. But there are enough ways like alcoholic rubs which are available for maintaining the hand hygiene between patients. There is a yawning gap. I'm very well aware. Private hospitals are mandated to have an NABH accreditation, and it's high time the public hospitals put their house in order and also go in for some accreditation when labs can do it. The tertiary care hospital labs in the city of Mumbai are all NABL accredited. Why can't they be NABH accredited also? We have to really work hard with the system, with the administration, to have trained infection control nurses to prepare training modules and implement them. We are, through MUHS, going to put together a course for training infection control nurses and ensure that at least in our hospitals, we are able to appoint them and ensure that they continue to work in infection control and are not removed. The model which is followed by a private hospital is authorization for prescribing higher antibiotics. This is extremely important. When the pipeline is so narrow, you hardly have any new antibiotics. Authorization is extremely important. De-escalation of antibiotics as per culture and sensitivity report is again important. You start with a higher antibiotic and then you de-escalate. Use of rapid tests, as I know, told you about rapid tests for detection of resistant genes and rapid tests for knowing whether you're dealing with a bacteria or a virus. And there has to be infection control and antibiotic audit. There has to be an audit in various departments, in various units of the department, in order to find out which department, which unit is consuming most of higher antibiotics. Are they de-escalating? That should be the role of the hospital infection control committee. Generally, the hospital infection control committee meetings comprise of sharing data of various infections and various antibiotic sensitivity and resistance patterns. Are the clinicians serious about it? Are the clinicians taking a note of it? Are they changing their practices? Is it going to contribute to a good antimicrobial stewardship program? These are the things which we really need to be doing and need to work on. So, what is the concept of One Health? One Health is an approach that recognizes that the health of the people, the humans, is interconnected to the health of the animals, poultry, and the shared environment. How humans can always get infected with animals, they can get infected from the environment, they can be there could be many reasons due to climate change. So there has to be an intersectoral coordination. Without urgent coordinated action, the world is heading towards a post-antibiotic era in which common infections and minor injuries, which have been treatable for decades, can once again kill. This is a statement made by the World Health Organization. Are we taking it seriously? We are all talking about it. We are still in the advocacy stage. We are aware, we are doing a lot of advocacy, but addressing AMR in community health requires a comprehensive and coordinated approach that involves the participation of various stakeholders in healthcare, in agriculture, in food industries. You need to have even the solid waste management officials. So, can we all come under one umbrella? Yes, it is possible. ICMR has put together a very robust One Health program with a One Health center, which is going to come up in Nagpur, looking at all these issues, trying to come up with some regulations about antibiotic use in farm animals, in aquaculture, and also trying to do some surveillance in birds, and trying to see how we can limit the spread of these drug-resistant organisms. Now, when we talk of tackling antimicrobial resistance, there are very important areas where we call them as the thrust areas. Yes, public awareness. Educate the public for proper sanitation and rational use of antibiotics. I can just give you one example that during the COVID-19 pandemic, number of diarrheal diseases reduced tremendously. And why did this happen? Because people were washing their hands frequently, which means it is not difficult to educate the public. So it is again important for the public to know that when you, what does improper sanitation lead to? Sanitation and hygiene in healthcare practices and good infection control practices is extremely important. You cannot give subtherapeutic doses of antibiotics to animals, either prophylactically or in animal feeds to promote larger, plumper food products. This has to be banned. And how can we bring about that? Only when all the heads come together, they brainstorm and come up with a common solution. You have to prioritize development of vaccines. Why vaccines? Because once you give vaccines, the chance of getting infection itself is reduced. When you have a low chance of getting infection, then giving antibiotics the question does not occur. We need to have a good surveillance system. We need to know where we stand. Countries need system to track cases, report globally, and make better policy decisions. We cannot hide facts. If you hide facts, we are sitting on a time bomb. We are waiting for it to explode. There has to be rapid diagnostics. Medical labs need to be equipped with rapid identification methods. We have to invest in research and development of new drugs and rapid diagnostics. Use antibiotics wisely, rationally. They must be prescribed and taken correctly. OTC, we all know, over the counter availability of antibiotics is causing a huge problem, and it's alarming. Many a times, if you stand in a chemist shop, you will hear people coming and saying, I have respiratory infection. What am I supposed to take? And the chemist, most of the times, cuts the strip and gives an antibiotic dosage for 3 days instead of 5 or 6 days. What does this amount to? You are making the bacteria static and not cidal. If the cidal means killing the bacteria takes 5 days, in a static dose, you are promoting the flourishing of drug-resistant mutants. Drugs need to be given in the appropriate dose at the appropriate time and appropriate period. These are the things which is extremely important for public awareness. Then there has to be a need for surveillance. What is surveillance? It's a systematic collection and analysis, interpretation, dissemination of data on antimicrobial resistance. You have to understand the extent of AMR, which helps to identify high-risk areas, population, and prioritize intervention. Detect and respond to emerging resistance. We cannot just keep quiet. That is why audits are important. Every hospital should invest their time, energy, resources in audits. Audit is the first step towards a good antimicrobial stewardship program. Support research and international cooperation is again important for tackling AMR. So this is the annual report, which is released by the ICMR. They have done thorough surveillance across the country, and this report is worth reading because the report clearly says that poultry, the resistance has increased, whereas in animals, by limiting the usage of antibiotics as co-growth hormones has reduced, and therefore there are a number of organisms which are sensitive, like Pseudomonas is sensitive to piperacillin tazobactam. Then why are the clinicians giving colistin? So these are the questions which are answered by a good audit. We need to have good advocacy at all levels in medical schools, hospitals, community, state, country. We all should have a common voice. We all should talk the same language, because I do understand that talking about the same thing again and again can bring about some amount of attitudinal and behavioral change. So we all have a role to play. Animal safety professionals, prevent disease, maintain records, educate people who engage with animals on disease prevention, stay current, commit to antimicrobial stewardship program, implement practice level stewardship, conduct surveillance. This is very, very important. Researchers, essential for discovery and development of new antimicrobial agents, develop technologies for rapid detection of AMR, understand the underlying host responses to infections, define alternative pathways to control infections, and improve rapid diagnostic technologies. Educators, understand the magnitude of the problem, educate and disseminate, and stop overuse and misuse of antibiotics to combat resistance. When we say understand the underlying host response, there is a lot which we need to do in this area. And clinicians, it's very important for you to give it a thought. Are you doing the right thing by giving high antibiotics and not de-escalating? The number of antibiotics available to you is very limited. Tomorrow, you may not even have these antibiotics. So as I said, we all have a role to play. Government officials should implement the One Health approach for disease surveillance, integrate data, monitor networks, policies have to be made, and there has to be financial resources for various programs. Administrators have a huge role to play. They are in the forefront of the battle because they need to implement antimicrobial stewardship, advanced diagnostics, information technologies, staff training, and audit. So I think that is the first thing which we have to do. So if you ask me, who are the first people to be contacted for a good antimicrobial stewardship program, it is your own hospital administrator who has to put his house in order and then ask for resources for better programs. Healthcare providers, of course, we all have a commitment towards a good stewardship program. In clinical decision team, there should be a team which comprises of the clinician and the microbiologist with rapid exchange of information, use of appropriate diagnostics, and know when to report cases to the health department to help identify unusual resistance. It is like reporting an unusual pathogen. So this is a cause of concern. So we all need to be alert. It will be extremely good if we have antibiotic policies which are, relooked, and all the risk questions are addressed. Hand hygiene is the most important. Use antibiotics appropriately. Be aware of change. Practice healthy habits around animals. Prepare food safety manuals. Stay healthy. Get vaccinated. Let the antibiotics do their job. So what has India done? We have a national plan. There is a national policy. Health Ministry has initiated a red line campaign, and colistin is banned in the animal food industry. So the action plan is very concrete, and it addresses number of areas in education and training, surveillance, infection prevention and control, ensuring prescription sale of antibiotics, labeling of food from animals, and strengthening of necessary law and regulation towards environment risk assessment, extended producer responsibility for expired, unused antibiotics. We cannot throw antibiotics which are not used in the open. Once you do that, you're contaminating the ground soil, and these are the places where you can grow your plants. Just a last couple of slides. We are moving now from phenotypic to genotypic identification of AMR genes. Whole genome sequencing can give you a lot of information. When we talk of sequencing, it can be targeted against the known genes, and whole genome sequencing will tell you about the unknown genes also, and it provides information on early emergence and spread of AMR for timely policy development. And it will be a very good tool for rapid diagnosis. Today, it is expensive. If the demand increases, if there is activism from the clinician, the cost will go down. It will be like your COVID testing, like your RT-PCR, which was 2,000 rupees, but during COVID, we could give it to you for 30, 40 rupees. So if the demand increases, the cost goes down. We at Kasturba Hospital have set up a genome sequencing center for surveillance and outbreak preparedness. And we are very well equipped with high-end machines like NextSeq 2000. This was the slogan of WHO way back in 2011. No action today, no cure tomorrow. And today we are in 2023. Have we come a long way, or we have taken some baby steps? I think we are still dragging our feet, and a lot needs to be done. All the various stakeholders need to come together and address the issue of One Health, where people who protect human, animal, and environmental health and other partners, they coordinate, communicate, collaborate to achieve the best health outcomes for people, animals, plants, and our environment. And this way, we are able to a good antimicrobial stewardship program can be instituted in hospitals to combat drug resistance and efficient healthcare. Thank you very much.
Yes, ma'am. Very lucidly presented the entire spectrum of antibiotic resistance, and just loved the way the slides were made. Actually, very very informative, and at the same time easy to the eye, and very easy to understand the entire concept of what an antimicrobial resistance is all about. And really, I think I am sure everybody went into a thinking mode as to what are we doing and where are we going and how are we going to overcome this huge problem. And the way you put it across means it's like right from plants to animals, and everything being involved in one complete cycle. So I mean, multiple steps we have to take preventive measures if we have to overcome this huge problem. And as you rightly said, administrators need to really pull up their socks and really think about this. But it's basically something which is really getting out of hand. How much ever you try, especially when you work in a hospital setup where, say, you have around 500, 600 beds, and you have so many consultants. And I'm talking about a teaching hospital also, where residents form a huge part of our, treatment part of where the treating part of the patients is concerned. Most of it is resident dependent in our public hospitals. And irrespective of how many ever sensitization lectures you take as soon as they enter into the residency program, as to how they should judiciously use antibiotics and things like that. But when left alone, what especially the surgery residents, ortho residents, residents in the ICU, as you rightly said, that you should have authorization to prescribe. I mean, that is definitely not there. There's nothing like authorization to prescribe. They just prescribe right, left, and center, due to which I think the problem is getting bigger and bigger day by day. Of course, you very elaborated it so well that at what steps we can take preventive measures and see to it that we get some kind of a control. But it's a huge task, it's a mammoth task, and would require a lot of efforts and a lot of people coming together to overcome it. So, anybody else, if you want to say something, Dr. Abhay?
I will request from our university department faculties if they can express their thoughts. Because we are conducting this lecture series, it is for the benefit of community and our departments also. And it was one of the best presentation because we have seen number of presentations today. But content and delivery is very appreciable from our point of view. Most important thing I would like to say that
Who's there? Where is it?
So,
Dr. Sen is there?
Yes. And we are proud that Dr. Jayanti Shastri is our chair professor of university. Such a like to work under her guidance. One point I need to add here. Every time we discuss about only antibiotics and microbial, but if we see our body, it is the microbiome. So it is not like that each and every bacteria is harmful to us. So we must learn how to deal with the microorganisms that we have learned in the last COVID pandemic also. Because in earlier phase we were against with the COVID virus, but afterwards we learn that how to live with him. Because as Madam has told us, that bacteria and viruses are more older than us, and they are being here after our end also. They will come, all human will destroy, but the bacteria and virus will be there. So we should not be against them. We should learn to live with them. And this is the philosophy. My background is from IRS side. So we should not think that everything is against. So it is not anti to the microbiome. We must learn to live with them. With this word, I will stop here. I will request anybody from teaching departments. Dr. Sensor is joined.
No, he was not getting in admission, so he's on the YouTube.
Okay.
Ma'am, I just wanted to know, you mentioned about a course that we are planning to do for infection control nurses. So, how exactly do you conceptualize this?
So, Madam, there are two things I would like to tell you regarding your question. Madam, I have worked in the public health system for almost 4 decades. Bringing about attitudinal and behavioral change seems to be the most important thing in any antimicrobial stewardship program, because antibiotic use how can you keep on insisting with every batch of residents? There have to be SOPs. I am only saying everybody has a commitment and we should all be committed to the cause. In fact, we had the privilege of working with one of our previous directors in 2013 who made us prepare a manual specialty wise, but that is possible only for outpatients. So we had color coding and we had made a specialty wise handbook for the use of antibiotics in various specialties for various infections. But when it comes to the hospital, it depends upon your hospital bug and what is your sensitivity pattern. In fact, we have no teeth when we sit in these meetings of HICC. We feel like telling the clinician, look at your antibiotic usage, look at your sensitivity pattern. We do not have that kind of power given to us. So I said administrator. Administrator has to be extremely forthcoming if you want to bring about a change. The second thing about the course, ma'am, we have already initiated, there are 2 courses which we are planning. One is for healthcare professionals. This is along with our advisor, Dr. Camilla Rodriguez from Hinduja Hospital. So we are coming and we are putting together a manual as well as an online course for healthcare professionals because there seems to be a gap in everybody's understanding. So we have already had our initial meetings for that. Second, infection control nurse is mandatory for implementing any infection control program. So we have to empower. For empowering, the first thing is give them knowledge. So through our center, we are putting together a certificate course of 6 weeks and empowering them. But ma'am, I will tell you my experience in Nair Hospital. I had to face the union. The union said that they go as infection control nurse because they don't want shift duty. It is not like that. People are very passionate about the cause and they spend their own money to go to Tata Hospital, who runs a course with SNDT University. And they spend their own money because they want to learn more because at one point they get stagnated. So how through the university, ma'am, this is a humble request that through the university, if we could insist, because now even NMC is, I met our medical microbiologist who's in the panel at NMC last week. And she told me that NMC is coming up with a document about infection control in the various hospitals and the role of infection control nurse. And we could possibly make use of that and ensure that in Maharashtra medical colleges, at least we can bring about this change. And we will, of course, train all nurses, at least 2 nurses from every college of Maharashtra in this course which we propose. And Dr. Saurabh has also been helping me with some international faculty for putting together this course of infection control in healthcare professionals. So we are thinking of an online module because, ma'am, it's very hard to get participation nowadays. Nobody wants to learn. I don't know what's happening to the younger generation.
If I can just add.
Yes, Dr. Sen.
Like Dr. Shastri was mentioning, so I guess Madam was mentioning the person NMC is Dr. Nag.
Yes,
Nag,
Dr. Vijay Lakshmi Nag.
So he took out the letter that was in 22, which asked all medical colleges to give a program. And I think again it has died down. So we can dig out that letter, ma'am, if you can ask Dr. Nag. Again, we can ask a situation report from all the MUHS medical colleges. What have they done? Because it was supposed to be preparing a set of lectures, a body, and it was cross MBBS, including clinical and paraclinical subjects, to conduct and give a progress report. But I have a feeling it has died down. So based on the garb of that, we can, if I may say, revive it and be ready then to wait for a knee-jerk reaction by individual colleges that on that one day when NMC suddenly takes out that paper and says that what have you done about it?
So for that, let us just put our course together. We'll get it vetted by the committees at MUHS. And once we are ready with the course, we start training our own people. Our house will be in order much before the other parts of the country.
Ma'am. So, ma'am, what I was saying that I'll also search. I remember this was sometime in March or April of 2022. This letter came from NMC to all medical colleges. Otherwise, we can take it from Dr. Vijayanath.
Sure.
And we can ask from the office of MEHS Dean Academy for everybody to give their report as to how they have implemented. And if, I mean, at the level of MEHS, let's work it out, ma'am.
Madam, infection control audit is also very important. Because, ma'am, what is happening in private hospitals, private medical colleges, they're going for NABH because a lot of funding depends on NABH. So, and credibility. So, when there is NABH, there is a mandatory requirement of antibiotic audit, infection control audit, how audit needs to be done. Ma'am, I would really like to take up this, as the first thing. We have professionals who can train even online how to do an audit. The only request is, can we bring all our medical colleges on board? It could be virtual also. Between myself and Saurabh together, we can, plan this sort of a. So it's like telling us where we stand.
Madam, thank you very much, madam, for your elaborate lecture on antimicrobial, very important topic. I would like to thank all the participants who have joined through our Zoom as well as YouTube platform. And once again, I thank you, Jayanti Shastri madam, for delivering a wonderful talk. Your presentation was really good. Your every slide was very thoughtful. Congratulations, madam. Thank you so much.
Thank you. Thank you. Thank you very much.
Thank you, ma'am.
I'll call you Dr. Sen now. Okay, bye.